Hey everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. I'm excited to bring you another in our series of interviews with top leaders in health IT. And our guest today is Dr. Colin Banas. He's chief medical officer at DrFirst, and Shereese Maynard. She's co-owner at Nostradata Medical. Welcome.
Thanks, John.
Thank you. Thanks for having me.
Yeah, excited for the discussion. I think we've had you both on the program at different times, different topics. So it's fun to kind of bring you two together to talk about a topic that, is one of the most challenging topics in healthcare, I think, because it causes such a burden on the healthcare system and patients. So excited to dive into talking about prior auth. But before we go there, Shereese, ladies first, you want to tell us about yourself and Nostradata Medical?
Sure, I am Shereese Maynard. I have been around the healthcare scene, the healthcare IT scene for about 20 years now. I started out in pediatrics with a company called NASDAQ, and I've been a strategy officer for most of my career. I write policy. I 100% love this particular topic, and I can't wait to get into it.
Awesome. Great to have you here, Shereese. And Colin, tell us about yourself and DrFirst.
Yeah, Colin Banas, the Chief Medical Officer for DrFirst. Also been in the healthcare industry for over 2 decades, just like my colleague here. I'm an internal medicine physician by training, but have spent the bulk of my career in informatics, previously as the Chief Medical Information Officer for an academic health system. And then for the last 6 years, the Chief Medical Officer for DrFirst, which is an innovative e-prescribing company that does so much more now in the past decade plus around what I call intelligent medication management.
It's amazing how DrFirst has evolved, right? Of course, you've done so well in e-prescribing, but you do so much more. Like, you're an e-prescribing company, sure. It's like EMR vendors. What's an EHR vendor look like today, right? They do so much more. Kind of feel like it's the same with DrFirst. Well, maybe you could chime in, Colin. What do you think is the current state of prior authorizations? Obviously, DrFirst has an interesting perspective doing so many prescriptions and needing prior auths for so many prescriptions, but also your acquisition of Mindshift as well. So talk to us. What's the current state of prior authorizations?
I guess it depends on the lens that you are applying to it. The first word that comes to mind would be frustration. Frustration on behalf of the patients, frustration on behalf of the providers. Opportunity is probably another good word, for companies such as ours, trying to streamline and remove the friction in these, often burdensome processes. There is a lot of opportunity, a lot of green space, and growth, right? Prior auth is on the rise. Specialty drugs, specialty authorizations, they are on the rise almost at an exponential rate. And there's no sign of it stopping as more and more new drugs get developed. Obviously, for the past 18 months, we've been dealing with the GLP-1 rush. And of course, there's a lot of prior authorization that goes into to things such as those drugs. And so, but it is also, and I'm sure Shereese will get into this as well, this is becoming front and center topic for healthcare at large. There was a huge testimony yesterday on at the House around the cost of drugs and PBMs, et cetera. There's lots of regulations and legislation that is, on the books related to interoperability and removing the burden. And so this is probably front and center in the minds of most people as something that needs to urgently be tackled.
Yeah, absolutely. Shereese, what would you add? And maybe let's dive a little deeper into the kind of the cost to clinicians, patients, even the payers. I think it costs them a lot of money because you have the cycle of people requesting prior auths and they have to respond. So, what's your perspective on where we're at with prior auths?
Well, when it comes to prior auths, I always say it's the CNC, critical yet contentious. So you can, we need it, right? We can't live in this healthcare world without prior authorization. However, it's a very contentious system, and I believe the reason why that came to be, it's my opinion that when we designed the whole prior auth system, it was designed to what? Control costs and ensure appropriateness of care. However, in building that system, we failed to acknowledge that the opposite exists. So it was just built on those things instead of considering who's going to use this process, physicians and patients. And I always say the greatest thing you can give a doctor back is his time with patients, his time learning, his time understanding the diseases that are with patients. And when you remove those things, you take those things away from them, you create a burden for them. You see greater burnout. You see gaps in care. You see patients slower to get the care that they need. Sometimes they will blame it on like a pharmacist or a physician. But I always say when I get in those conversations, I'm always quick to tell them, like, hey, if you knew what was going on behind the scenes, you would know that your doctor wants you to get the care you need when you need it. But there are gaps in the system that slow it up. I call it a duck in water, right? So the patient only sees the doctor, the pharmacist, they're smooth going along, but underneath they're pedaling, getting those prior offsets. So that's what the patient doesn't see, but it does create those gaps. And I think, fortunately, while prior auth is growing, like my colleague just said, they're also causing systems to take a closer look and say, maybe we don't need all these prior auths.
Yeah. I mean, I think you bring up an interesting point. The fact that the doctor, the pharmacist takes the blunt of the blow. The payer doesn't hear from the patient, right?
Exactly.
Because there's no way for the patient to call the payer. I mean, there kind of is, but it's hard for the patient, right? Their interaction is with the doctor or pharmacist, and so they take the blunt of the blow when the payer is the one that might be slowing the process. And I think that
Mm-hmm.
that's what gets lost in this discussion sometimes. I hear a lot of doctors saying prior authorizations suck. It's a pain in the butt. Why are payers, practicing medicine? They say these kind of
Mm-hmm.
inflammatory things, which is understandable from their point of view because they see this as a necessary medication for their patient. But what they don't often acknowledge is that the payer has a challenge as well, which is people abusing it, people overprescribing, people doing unauthorized things. I remember talking with a friend of mine that I play ultimate frisbee with, but she's a doctor and she works in a lot of the prior auths, and she's like, John, you should see the things that doctors prescribe or that they are asking for a prior auth on where there's no medical evidence. And so I think I think it's good to be sympathetic on both sides about why this process even exists, right? Colin, what would you add as far as the cost to the clinicians, patients, and then payers as well?
Yeah, I think Shereese nailed a lot of this. There's financial cost, right? There are teams of people in these offices whose sole job is to work the prior auth queue, and a lot of that queue is still manual. We're talking phone calls
Mm-hmm.
and faxes and snail mail, and you're devoting a small army of people to making sure that this stuff gets done. And I do recognize both sides of the coin. I think balance is necessary in all things medicine. But there's also the flip side of that is that there's a patient cost, right? There is depending on what you look at, there's stats that say a quarter of patients end up abandoning the therapy because the prior auth never gets completed or it's too onerous on some side of the equation. 9 out of 10 doctors think that it has led to some form of a adverse outcome or adverse impact on their patient. A quarter of them think it's led to a serious event or even a hospitalization because of delay to therapy. And so there's, the clinical cost is probably even more so important than the financial and the burnout cost. But it all represents a drag on the system. And Shereese said it very, very well, which is, what could I be using those resources to do otherwise if I wasn't devoting it to something that isn't always necessary? That's the hard part, is figuring out when the prior auth is actually doing its job and redirecting to appropriate care and making sure appropriate funnels are being put in place so that it's not just hog wild, versus the specialist who clearly knows what the heck they're doing and is writing for this drug for the 1000th time and is still having to jump through these hoops. And that's where you see a lot of these legislation, even at the state level, getting involved.
Mm-hmm.
We could talk about gold carding, where once you've sort of demonstrated that you're not one of the abusers, that you do know what you're doing, you're going to have much less onus to do the prior auth. You might even be able to prescribe at will without doing this because you've demonstrated the appropriate competency. But, it's all very nuanced, and it's, balance is the key.
Yeah.
Well, and I also think if you think about not just the burden on patients and providers, which certainly that is top of the conversation, but I think even prior auth payers, their organizations don't realize the cost that is coming to them. They see it as cost efficiency, but that's a short-term goal for a short-term gain for them. Long-term, they may be increasing costs because if care is held up. And prior auth is, like you said, it's certainly so much still in paper mode, slow motion, snail mail, and that type of thing. They might be holding up care to a patient who might get sicker, therefore increasing the cost of care down the line. And if you look at now with Americans having, you know, two chronic care conditions, and you look at physicians who have 14 hours of administrative burden for prior auth per week, what we're saying is long term, this is costing money. It's not safe. It's not cost efficient.
Yeah. Well, and I think this is the challenge in healthcare. How do you put a number or a value on someone that might even lose their life or their quality of life because they didn't receive the medication they needed in a timely manner, and it causes complications like Colin talked about. But it's like you can't do an ROI on a life, right, or quality of life. And so I think that's what makes the discussion so challenging. But what I think is clear, in this discussion is prior auth is a burden on doctors and patients and should be, and that burden costs payers as well. And so we need to improve it. Colin, you mentioned some of the regulations that are happening, I think federal and state level, because it's such a problem. Everyone's trying to address it, and they want to reform the prior auth process. Do you think these new regulations are going to make a difference? What do you see as some of the opportunities and maybe some of the limitations of what's passed already?
Yeah, it's such a complex ecosystem that we're talking about here because CMS has a piece of a part of it, but doesn't necessarily have any dominion over the private payers or employer funded, insurance plans. The states have a piece of it, but if each state has their own little different version of how they want to regulate this. Interoperability, even though we've been talking about it for 15 plus years now, is still not at the level where it should be. Any other industry would not tolerate this level of failed interop. And I know I'm being a bit harsh, but can you imagine, retail, aviation, banking?
Banking.
Yeah, it would be out of business. Like, it's not even close. And so, we've continued to take the crawl, walk, run approach. What I would say is that within this last year, I've seen some big swings from both the federal government and from state governments. The federal government got really serious about requiring API access for payers to connect to payers, payers to connect to patients, payers to connect to providers. Some of that excludes medications for now, but it's coming. You can tell they're laying the groundwork. Obviously, we've talked a lot about TEFCA in the last 2 years, where we're trying to have this at least basement level of interoperability among providers. And then lastly, as I mentioned before, you're seeing this get a lot of attention at the legislative level, both from federal and states. And there's a lot of laws on the books. I think Illinois just passed one within the last week that said, hey, if it's a prior auth related to a Medicaid patient for mental health, like, you can't do it anymore. Like, for someone who's admitted, basically they're saying someone who was in a mental health crisis, this mental health provider has the dominion to pick the drugs they want to pick in order to manage that crisis without having to go through a prior authorization. Same thing with you see a lot of legislation bringing down the expected timelines. 14 days used to be the norm. Now you're seeing 7. And if the provider says this is emergent, you got 1 day, Mr. Payer, in order to respond to this. And so, as I said, I think attention is the key. I also think, and we'll probably get into this, I think there is a huge role for technology in improving this process as well.
Yeah.
Oh, definitely. Even with the EPA. But I would go as far as the legislation. I would go further. I'm one of those people who believes less is more, and I think every time legislators see what they think is a hole in the system, they create more policies, and that complicates the whole prior auth system more. I think what needs to happen is that people need to look at the prior auth system. And I always like to give analogies. I compare it to like buying shoes. We keep saying, oh, a doctor or a system or a patient will say, hey, my shoes are too tight. And instead of changing things, we go and just get them another style of shoe, not changing the size. So I always feel like they're saying to us, this is hard, this is complicated, this is holding things up, and instead of fixing the problem, we're bringing them another version of the same thing. We have a lot of EPA systems, electronic prior auth systems. None of this is speeding up care. It's creating another thing. So I think organizations, state and federal, and 100%, I can tell you Medicaid is the worst because Medicaid for prior auth makes us measure in 15-minute units, which is ridiculous. So it really needs reform. But I think the whole idea of having more and more laws is further exacerbating the problem.
Hmm. Yeah, I mean, I think there's plenty of organizations that hide behind the regulations, right? And
Mm-hmm.
use the regulations to muddy the water for
Yeah.
actually accelerating payments versus not. But, I mean, to your point, Shereese, if you have to snail mail it, if you have to fax it, you're slowing the process. And I think, Colin's right. There has been a big push to say we need to do electronic prior authorization so that we can do real-time adjudication of those prior authorizations. And we see some doing that. I mean, I've heard of
Mm-hmm.
Blues plans saying, hey, for general medicine, we're doing away with prior authorizations, and doing some things like that. So there has been some at least recognition of the problem. Where else do you see like the greatest opportunity to improve prior authorization currently? For me, it's does the prior authorization, is it even needed? Right? Like, like that seems like the number one problem where, many or doctors, clinicians are sitting there and being like, do I need it? Do I not? And they're not sure, right? But what would you add, Colin? What do you see as kind of the greatest opportunity to improve prior auth right now?
Yeah, there's a couple key buckets I would put. Transparency is the first one that comes to
Mhm.
mind. It is so difficult for even the provider in the know who's probably been doing this for decades to figure out how the rules have changed for what drug and for which payer and which hoops to jump through and how to provide the documentation. And then, of course, every year it changes or the patient,
Changes.
yeah, or the new drugs come along. And equally on the patient and the pharmacy side, excuse me, there, I get more transparency around my pizza order than I do around, my life-saving drug. The pizza tracker is actually a thing of beauty. It's ordered, it's received, it's in process, it's in the box, it's on its way. And so I think transparency is one of the big ones. I think we're also in an interesting hybrid period of time where until those base levels of requirements, those APIs and expectations are fully built out, which truthfully won't see realistically until 2026. And who knows, they might kick the can down the curb yet again. So we're in this hybrid period where there's still going to be manual processes, but there's also a huge green space for things like robotic process automation and artificial intelligence and LLMs to fill in the gaps until these standards are fully met. And that's you mentioned mind shift at the start of the recording. That's one of the great things about that acquisition for DrFirst is that is exactly what that company is doing as we speak. And it's doing it not only for pharmacy benefits, but also for medications that require the medical benefit, which is also on the increase as well. Typically, your high dollar infusions and injectables.
So talk to us more about that. How does it help to solve the problem? Because, it's funny when you said that, I was like, it's a bad system when the only solution to it is institutional knowledge to solve, is this a prior auth needed and what's the way to navigate it? And this payer does it this way and this payer does it that way. Like that is a bad system. If the only way is that you've been doing it for 20 years and you know the pains and it changes every month. But talk to us more about Mindshift. Like, how does it address it? Is it creating an electronic platform to be able to do it? Is it, how are
Yeah,
you working to solve it?
yeah. One of the main things it does is that it is basically creating a compendium on our end of these are the payers, these are the rules, these are the forms, these are the expectations. And then, and it's doing that with some, very fancy robotic process automation, maybe even some screen scraping and, AI. Of course, you can't go anywhere these days without talking about the power of AI. And then we're going to, on the other end of it, is understanding those rules and understanding those forms. Now, how can we help automate the creation and the eventual submission of those forms? And so there's sort of like, 3 or 4 different buckets that the Mindshift platform, and it is definitely a platform where you can where you are aggregating all of the requirements and then also creating the submission and then actually submitting it and then tracking it, in a dashboard style. And so it is a very powerful platform.
Interesting. It's taking all that institutional knowledge and putting it into technology. That's interesting. Shereese, what would you add as far as the opportunities here to improve prior auth currently?
Well, there's a couple. The If you think about like automation, we know that AI can take data sets and break it down and tell you, predict what procedures and stuff are likely to be approved, how long it'll take to get. So we can use data-driven AI for that purpose. That's the first thing. The second thing is for to have some standardization of the rules, and another way under that is to have like real-time prior auths, which we don't have. And if you think about somebody, I always think about oncology. If they're in stage 3 and they need certain things, they should be able to get an answer to that quickly instead of having to wait. But the other thing that I think will be a game changer I always say about the fishermen. So for the longest time, prior auth payers depended on that to not only save the money for under care, but also for them to make money. However, Amazon. So Amazon in this space, I think, is going to be disruptive for prior auth. I think the way they're developing their medical models and the things that they're studying right now are going to make a difference. And one of the impact we've seen with that is um, that's why I would say fishermen always see another fisherman coming. United Healthcare has started saying that, oh, okay, for these particular procedures, you no longer need a prior auth. Where before it was like you absolutely have to have it. And I'm like, if we can get to a future where we don't need prior auths because we're able to take data and AI and determine what is likely to happen with the patient, what is likely to be approved. I think that that's where the money's going to go, and I believe that Amazon is going to be big in that transition. I predicted that. I'm sticking to it, and I say by 2027. I know Doc said 2026. I'm saying 2027. We're going to get more standardized policies for prior auth, but we're going to see less of them. So, and I think a large driver of that is what Amazon is doing right now.
Yeah, I mean, retail health and that direct to consumer
Mm-hmm.
model is kind of forcing the hand of
Yep.
payers to say, "Hey, we can do this for cheaper." I mean, we saw that in the drug space, right? With some of the
Mm-hmm.
inexpensive drugs that people are selling at a loss, even, right?
Mm-hmm.
Forced hand of pricing there as well. I think that's interesting. Although I think you highlighted the biggest point for me, which is doctors and patients mostly just want a consistent response from the
Yep.
payer. Like right now, you go into it knowing, okay, I have no clue what they're going to answer. And so, being able to, have that consistent payer response, I think that's a huge opportunity, for healthcare to improve this process so that they at least go into it knowing with some sort of certainty what's going to happen as opposed to just guessing, how are they going to feel today? It's almost like many
Mm-hmm.
of our us. It's like, they wake up on the right side of the bed or the wrong? I don't know. We'll find out. I think that's frustrating for an organization, especially when you're giving care. So Let's look forward. Shereese, what would you see as kind of the ideal state for prior authorization in the future? And we kind of talked about how long it will take to get there. Like where, what do you see as that future state? You offered, was it 27 is what you were looking for?
27.
What do you think that future state is going to look like? That ideal state for prior auth?
I think you're going to see less of them. Like I said, we have technology now that can determine what a patient's real needs are. Everything is getting more independent or to the individual healthcare and that type of thing. So we can now determine, okay, this is really needed. Payers see that same information, and you look at a payer. Let's take United Healthcare for one, because let's they made $9 billion last year. So what are they going? They have to research the prior auth issue because they have such a large share of the market, right? And like I said, they're studying Amazon, like Amazon studying the market. So I think the ultimate the paradise of prior auth is to see less of it, because I really feel like we're at a place where we don't need to clog up the systems or create greater gaps for patients. And it also brings to mind that maybe with prior auths, the way we're doing them with Medicaid and all that kind of stuff, further marginalizing patients. So in a greater universe, we'll see less of them across the board. All payers will say, maybe we don't need to put these in place for everything that we're doing now. Let's remove some of those burdens. And I think for some um, vital care like mental health, and I was going to mention like emergency care. Already, you're seeing, oh, you don't need if they're coming through emergency with these type of situations, you don't need a prior auth, just treat them. And that was thanks to private equity. They're like, we're not doing that. So I think in a perfect world, we'll see less.
Hmm. Well, I think we have the data now to
Mm-hmm.
know, whether it's on the provider level, like Colin talked about before, that hey, we need to stop doing prior auths because this person doesn't
Mm-hmm.
abuse us, or whether it's on the more aggregate level that says, hey, when this is prescribed, it's needed, or we have more data to help
Mm-hmm.
avoid it. But I would say a real-time prior auth that's approved is like a no prior auth. If you're
Mm-hmm.
able to reach that's like the prior auth not existing if it happens in real time. So I like that idea. Colin, what would you add? What do you see as that kind of ideal state for prior auth?
Yeah, I think the big themes are consistency, transparency, and automation. So we have a vision at DrFirst to, be fully automating over 80% of the prior auths, but basically hands-free when they are required. And I think Shereese made a great comment. Not all of them are required. I think there's a lot of work we can do on both ends of the equation to funnel it down to this is really only the times when you really need to do this. But consistency, transparency, automation, and then ultimately, why are we doing all of this? It's for outcomes, right? And so
Mm-hmm.
how can we make sure that we are measuring the appropriate outcomes, not just speed to therapy, but actually did it work, and then feed that back into the system to say, you know what, when this process has been followed, the patient outcome improves by 25%. Let's start moving the levers a little bit so that we can adjust the process and basically make a continual learning healthcare system.
Interesting. I'll throw one other out there. Ambient clinical voice, which is capturing all of the data that's happening in the exam room between the patient, the provider, other automation that's collecting it from the patient beforehand. They're not going to be filling out forms. They're just going to describe everything. So we're going to have this explosion of data that's going to be recorded, and that data is going to help us do prior auth quicker because that data will justify the actual thing that's happening,
Mm-hmm.
be able to automate it using that data. So there you go. There's my view. And that ideal
Well,
state is having the right data to be able to approve the prior authorization quickly.
oh, 100%. The cynical side of that is that we are about to enter into a perpetual arms race where
Yeah.
we are using AI to fill out the prior auth, but the payer using AI to systematically deny the prior auth, and actually it's a little tongue in cheek, but there were reports of that happening prior to Christmas in 2023,
Yeah.
where some of the big payers got called out for potentially using AI to to basically categorically deny claims without ever laying human eyes. And so there is some,
Yeah,
yeah.
that was pretty disappointing, actually, and I 100% did not see that coming because it seems to so antithetical to what you want to do for patient care, right? So why would you just group up all of those priors together and say nope, deny them all? However, I always caution that once upon a time that was the way it was done. So not through electronic means, but by written means, they would the payers would get a block of procedures, and they would their first line of defense was to deny them all. So it's not new. I was just surprised that they brought that back because it didn't work the first time. Um, so I think, like you said, transparency. I would love to see uniform policies for how we use the prior auth within organizations, payers, and that type of thing. Some standard practices. But again, at the end of the day, if we have automation, transparency, and um, the ability to generate real-time authorizations, I think that goes a long way. But ultimately, let's see some of these prior auths just go away.
Yeah. Well, Colin's the doctor here, but from my understanding of dealing with chronic care management and chronic pain, you have to be consistent. You need transparency of what's happening with your chronic conditions, and you need to treat it appropriately. I would say we have a chronic prior authorization pain that we need those same things. We need to treat it. We need to understand it, like Colin said, with transparency and understanding. So yeah, I think that's a good start to the problem. But appreciate you guys both for coming on to talk about this important problem, and I think we are making some progress. So I'm grateful for companies like DrFirst that are institutionalizing the understanding of prior auth to be able to streamline it for doctors and for patients because it is such an important thing. So thanks so much, and thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcast application. Thanks, Colin and Shereese.
Thanks,
Thanks,
John.
John.